My name is Brooke. My clinical in-service topic is frontotemporal dementia, specifically the logopenic variant of primary progressive aphasia. And this slide here just consists of some terms that you'll need to know about for this presentation. The diagnosis. So frontotemporal dementia, logopenic variant, primary progressive aphasia, or FTD lvPPA, is rare in frontotemporal dementia, but it is more common in Alzheimer's. It affects naming and repetition while grammar and single word comprehension remain intact. FTD lvPPA primarily impairs language abilities, leading to difficulties in speech production, comprehension, and word finding. These difficulties can impact reasoning, problem solving, and social interactions. The treatment focuses on improving daily functioning and quality of life through communication strategies. But there is no cure, unfortunately, for FTD lvPPA, but speech therapy is often recommended to enhance quality of life. As for causes, the exact origin of lvPPA remains unknown, but it is noted that protein accumulation in the brain, similar to Alzheimer's, leads to cell dysfunction and eventual death, resulting in brain atrophy. FTD lvPPA is a complex neurodegenerative disorder with multifactorial etiology. Risk factors for lvPPA include genetics, age, gender, smoking, traumatic brain injury, and education level. While these factors have been implicated in the development of frontotemporal dementia, including lvPPA, further research is needed to fully understand their contributions and underlying mechanisms. So for neurophysiological correlates, brain regions like the left angular gyrus shrink, affecting the phonological loop and causing difficulties in repeating and understanding sentences. Next, we'll discuss prevention and early detection of FTD lvPPA. So preventative strategies are unknown, but maintaining cognitive stimulation, physical exercise, cardiovascular health, and a balanced diet may help. Early detection involves neurological and neuropsychological evaluations, along with imaging studies like MRI or PET scans. Brain imaging reveals decreased glucose consumption in lvPPA brains compared to normal brains. So on the left here, you can see an lvPPA brain compared to the right image of a normal brain. A radar plot shows the language profile of lvPPA individuals, indicating fewer word combinations and more frequent content words. Now let's discuss the clinical presentation of lvPPA. lvPPA features slow speech with pauses, intact grammar, impaired naming and repetition, preserved word comprehension, and deficits in syntactic comprehension and single word reading. Differential diagnosis includes Alzheimer's, semantic variant of primary progressive aphasia, corticobasal syndrome, progressive supranuclear palsy, and other etiologies. Distinguishing between these conditions requires a comprehensive clinical evaluation, including detailed history taking, neurological examination, neuropsychological assessment, and neuroimaging studies. Collaboration between neurologists, neuropsychologists, and speech-language pathologists is often necessary to achieve an accurate diagnosis and appropriate management plan. Differential diagnosis of FTD, including the lvPPA, involves distinguishing it from other neurodegenerative disorders that can present with similar clinical features. And this chart helps to differentiate between primary progressive aphasia subtypes based on the language deficits. And then this is another chart that aids the diagnosis based on symptoms. Tools like the Frontal Assessment Battery, or FAB, and the Montreal Cognitive Assessment, or MoCA, assist in differentiation along with neuroimaging. The FAB is a cognitive test that incorporates several clinical assessments to screen for FTD, including S-word generation, similarities, Luria's test, grasp reflex, and the go-no-go test. The MoCA assesses short-term memory recall, 5 points, visuospatial abilities through clock drawing, 3 points, and cube copy, 1 point, and orientation, 6 points. And then it's just noted to exclude using the mini mental status exam, or MMSE, because it does not include assessments for impaired executive functioning. So that means it would not detect changes indicative of FTD. So CT or MRI head scans show frontal lobe atrophy patterns aiding diagnosis. You can see in the chart above where atrophies may occur in the brain based on the variant the patient with FTD has. Now, treatment recommendations. Recommendations include speech and language assessment, AAC device use, cognitive communication therapy, family education, and multidisciplinary collaboration. Semantic feature analysis is recommended to improve word retrieval and semantic knowledge. Preparing for SFA involves identifying target words and using visual aids to support word retrieval. So now for the steps for using SFA with a client aiding in word retrieval, it would look something like this. So first, they would see this picture of the item that they usually experience anomia with or word finding difficulties. And you want them to be able to answer, what group is it a part of? It's a utensil. And then we would ask them what its use is, and they would say it is used to eat. And then we would want them to think about, what does it do? And they can hopefully figure out that it picks up food, maybe discussing some of the properties, and they might say it has tines. Then we want them to ask themselves, where could we find this item? They would say kitchen, and then they would think about what this item reminds them of, and they might say spoon or knife, or some other utensil. And then ultimately, by going through all of those steps, it should help them find the word that they were looking for, fork. And evidence supports the effectiveness of SFA in lvPPA treatments. So some other factors are associated with FTD lvPPA. Prognosis involves progressive language decline, while therapy can improve communication, but varies in effectiveness. Overall, while lvPPA presents significant challenges in terms of prognosis and response to therapy, early diagnosis, comprehensive management, and supportive interventions can help optimize functioning and quality of life for individuals with lvPPA and their families. Ongoing research into novel therapeutic approaches and biomarkers may further improve outcomes for individuals with lvPPA in the future. So some quality of life considerations encompass communication abilities, functional independence, emotional well-being, social engagement, caregiver support, and access to services. Enhancing quality of life requires a comprehensive approach that addresses the unique needs and challenges of individuals with lvPPA and promotes meaningful engagement, functional independence, and supportive care for both the individual and their caregivers. So cultural, linguistic, and socioeconomic factors influence lvPPA experience and care, emphasizing the need for cultural competence and equity. So today we embarked on a comprehensive exploration of frontotemporal dementia, Focusing specifically on the logopenic variant of primary progressive aphasia, we delved into its intricate symptoms, diagnostic challenges, and treatment modalities. Through understanding its complexities, we shed light on the importance of early detection, multidisciplinary collaboration, and supportive interventions. While lvPPA poses significant challenges, our journey also highlighted avenues for enhancing quality of life and promoting meaningful engagement. As we conclude, let's carry forward our newfound knowledge with empathy and commitment to improving the lives of those affected with this condition. Thank you for your attention and engagement. Here are some references that I used. And thank you for watching. I hope you were able to learn more about frontotemporal dementia, specifically the logopenic variant of primary progressive aphasia. Do you have any questions for me?